Thank you for having me here. Of course, at my age, I'm happy to be anywhere at this point, especially on Sunday mornings. What I really want to talk about is sort of how we use all our technology, and then make a comment about how I think that if we look at the patients individually and ask a couple questions, why technology becomes less and less important if we look at the patients. I see lots of times people just dump on anything you say. They tell you you have no idea what you're talking about. They waste your time, and then some people just listen to everything you say and believe you. And I think we've got to split the difference between all of those. And when you talk about AI right now, there are people that are prompt engineers. I think we spend too much time looking at the answers, not enough time looking at the questions. So prompt your patients, prompt what you're doing for surgery, look at the prompts you're using to ask the right questions. And I think that then the answers become a lot easier. The other thing is we become so focused on procedure, technology, we sort of forget that we're really looking at a patient-centric approach. So I always ask, what are we doing? Why are we doing it? What are the reasons that we're doing the surgery? And then where are we doing it? And what resources do we have at that location? And so I think that's really important. And what I'm going to show you first is sort of a new procedure. So what I'm going to show you is a new procedure that we can do with our technology, which we've been doing for about a year or so. And I know one of residents of my colleagues in the audience. So if you think I'm not telling you the truth, go and ask them afterwards. But basically, what we're looking at is a prone angle transpsoas. How do we use that? Basically, we were looking at going anterior, going angled, and taking advantage of all the other procedures of the best part. So best part of the D lift, we work directly laterally. Best part of the O lift, we start oblique or anteriorly. Best part of doing prone, in which we develop lordosis from positioning the patient in that way. And then that feeds into how we treat the patient and why we're doing it. So my goal here was to talk about when do we go laterally, when do we go prone? And the reality is I don't think you need to flip the patient at all ever again during any of your surgeries. So I like to make a declarative statement to tell you exactly where we're going, and I think what we're looking at is sort of a missed opportunity. We're focusing too much on the procedure and more about what we're trying to get. You can get anywhere by working prone from up at T5 to the pelvis in any location without having to worry about it. I also put a plug-in in the end at L5S1, which I think is a great reason to go oblique or go lateral or go anterior. I think that you'll see that a double stuff or a two-cage T-lift in the bottom is going to give you good distraction and lordosis. So I think there's lots of options that we're sort of not looking at. The idea of going, when you're prone, going anterior, going oblique, and accessing that allows you to do that. So why do we not need to flip the patient anymore? Why can we access any one of those pathologies in one position? Is exactly what we're looking at. The reason is so much faster, safer, and easy to position a patient prone. Doesn't take any time at all. You've got an easy frame. You get lordosis. The retroperitoneal space falls out of the way. You have access to the thoracic spine. You have access to the posterior column. You can change your mind during surgery if you can't access one or the other, or you decide you want to do a decompression. So I would tell you that although what I first started to talk about was when do I go lateral, when do I position the patient, when do I go prone, the fact is I do everything in prone position now, and I think we can access that very easily. The second thing is simultaneous access. So it makes a real big difference if you're working with a fellow, a resident, another colleague, in which you can work simultaneously in doing that. I think we'll look at two procedures, even if it's just putting stitches in at the end after someone's done the lateral and someone else is doing posteriorly. I think it gives you a lot more options to work when you're doing that. So let's look at two cases briefly. Really just looking at something that doesn't happen all the time. These are simple cases. These are not incredibly complex things, but they're things that you face all the time and you see. So in other words, a patient with a thoracic compression, T11-12, thoracic disc, anterior and posterior disease, compression in front and back, and severe lumbar stenosis from an L4-5 stenosis, which again, two simple procedures we're looking at. Not something you see all the time, but when you're sort of talking about doing something prone, you can access those very easily and do that simultaneously. One hospitalization, one procedure, one position, doing that. And I think that makes a huge difference when you're talking about it. I can talk to you endlessly about how we sort of put that together, but you get simultaneous access. You can navigate the entire procedure. And if you're doing something now that you can't navigate, you're going to be in trouble when the next generation comes through. So lateral surgery, you can absolutely navigate it with your lateral position, but it's navigation designed for prone. Much easier to do this in prone, much more simplified. And so that's what we do. We do everything in the prone position. This is a thoracic discectomy at T11-12, taking down the diaphragm, a nice little small incision in that spot, while my colleague is simultaneously doing an L4-5 laminectomy in the back. Very easy to get down there, very easy to look at. And I think what we're really talking about now is saving time, money, effort, and simplifying things and simplifying your decision by working in the prone position for whatever you want to do. And this is sort of where we end up. Don't always do a fusion for a discectomy, but when we went front and back and do a complete bilateral facetectomy posteriorly and an anterior discectomy taking down part of the pedicle in that location, we end up there. And so then how do we end up with a little bit more complex case? This is someone that's had a few surgeries in the back, a laminectomy, a nice adult degenerative scoliosis deformity, significant kyphotic deformity. Really what we can do in this location is position the patient prone. We develop lordosis automatically. We do what's a prone case at like 3 levels. One level T-lift posteriorly with the patient in prone position with dual cages that prevent subsidence, which we'll look at. And then if you need to, you do a release in the back with a preformed rod, calculating about how much correction you're going to get from each one. Going prone, using an angled or an oblique approach in the prone position, taking advantage of avoiding nerve roots, using navigation in this procedure without using fluoro, and using neuromonitoring to make sure you're safe. Putting all of those together allows us to do this in a much more simple fashion. This is where I go. I look just on the anterior aspect of the psoas, posterior to the vessels, and I think you can access this place very, very easily, especially at L4-5. So this is really the procedure that we talk about, going angled and anterior. And what we really get from positioning the patient prone, simultaneous procedure, increased lordosis, simplifying, using navigation, all of those put together get us there. And I think it's really important. The big advantage of lateral, I think, is an A-lift. I never argue that A-lift is not a great procedure, but the fact is we can start talking about anterior releases, anterior column releases in the prone position. We can start talking about putting 2 cages in or cages that fit together, which give us a decreased subsidence, excellent lordosis, especially from the prone position. So I think this brings us around to using navigation, approach in each location, position, lordosis, access, and that is going to bring us together to provide better outcomes. And I would encourage you to look at each of your patients and decide what you really need to do, especially for these cases, how we can access and how we can get down there for that. And I appreciate your attention, and hopefully we got in under 8 minutes, which was my goal. I have a minute to spare too. Thank you very much.
Thank you.